Okay, welcome everyone. So we're still on the gastrointestinal tract. We're going to be looking at the small intestine in this section. Now, the small intestine is a long tubular organ, and the small intestine is that union or junction between the stomach and the large intestine. Okay. So it's almost 20 feet. We're looking at 19 and a half feet long. It's about 1.6 inches um, in diameter. And it's going to occupy most of the abdominal region, except that the upper portion. If you think back how you had those 9 abdominal regions, so it's going to be located everywhere except for this top section here, right? So we can cross all of this out. Okay, so that would be the right and the left hypochondriac region, and then the epigastric region. So it's going to occupy most of the abdominal regions except for those 3. Now, the 3 sections of the small intestine are going to be the duodenum, the jejunum, and the ileum, in that order: duodenum, jejunum, and ileum. If we look at the color codings here, we can see the duodenum is the first portion. Then in like purplish pinkish, we have the jejunum. And then what we see here in the middle, the rest of it is going to be the ileum. So we have duodenum, jejunum, and then we have the ileum. And then what else we're seeing is at the end of the ileum, which is kind of like right in here, this region, this is the ileum. I'll put an I for ileum, the end of the ileum, and I'll put a C for cecum. So you've heard me talk about the ileocecal valve or the ileocecal region. That's the junction between the end of the small intestine and the beginning of the large intestine. Okay. So the duodenum is the segment of the small intestine that's going to be closest to the stomach. It's about 10 inches long, and it's going to receive the chyme from the stomach. The jejunum is the middle segment of the small intestine. It's a little over 8 feet long, and that's where most of the chemical digestion and most of the nutrient absorption is going to take place in the jejunum. And the ileum, which is the final segment of the small intestine, it's a little over 11 feet long. And at the very, very end, that's where we're going to have the infamous ileocecal valve. Again, the junction between the ileum and the cecum. And this sphincter is going to control the flow of material from the ileum to the cecum, right? It's going to control the flow from the small intestine to the large intestine. If this valve remains open too long, that's diarrhea. And if this valve remains closed, that's constipation. Okay. Now, within the intestine, uh, deep in the intestine, we have something referred to as plica circularis. So this is a dissection of what plica circularis look like, and they really are these spiral type of folds that are located in the small intestine that are designed to increase the surface area of the small intestine, and it's designed to really mix that chyme and to spiral it and mix it as it is traveling and moving through the small intestine. And that spiraling and mixing of the food or the chyme as it travels through the small intestine is really designed to allow it to mix and to move more uniformly so that the digestive enzymes are really surrounding all of the chyme, not just the outside of that chyme, but inside due to the way it's spiraling through. So what's in the inside moves on the outside, what's on the outside moves on the inside, and there's even distribution and mixing of all those digestive enzymes through the food. So this is what the plica circularis look like, right? These spiraling grooves so that food is churning and mixing evenly through here. And these tiny extensions coming off these villi are microvilli, right? So here you've got these columnar cells, and there's going to be little microvilli coming off of them that are designed to absorb the nutrients. So there's nutrients going to be moving inside of here. And if it's water soluble, it's going to move into the capillary network. But if it's fat soluble, it moves through the lacteals. So anything that's fat soluble, like vitamin A and vitamin D and vitamin E and vitamin K and coenzyme Q10 and fats, all the fats are going to move through the lacteal system, and all the water soluble nutrients move through the capillary system. Again, that's what the plica circularis. I mean, I try and give the visual of like a screw and a nut, right? You know how like you could put a nut and put it on a screw and it just turn it and turn it and turn it. If you take off the nut from the screw and you put your finger through the center of that nut, it kind of, you can feel the grooves around. Those grooves are like plica circularis. And that food is moving beautifully through there so that the digestive enzymes mix uniformly inside and outside of the chyme. The microvilli, this is going to be like they're a sponge, right? It's located on those columnar cells, and they're designed to increase the surface area and to increase the digestion and absorption of nutrients approximately 24 by 24 times. The functions of the small intestine, it's the majority of your digestion and absorption of nutrients is going to take place in the small intestine. And the part of the small intestine that most of it takes place is going to be the jejunum. Most of it's going to take place there. The intestines also produce some intestinal juice or digestive enzymes. They're going to produce intestinal carbohydrates, intestinal lipase, intestinal protease. So protease breaks down the proteins. Lipases are going to break down the lipids. Carbohydrases are enzymes that will break down carbohydrates. There's water. There's electrolytes. There's mucus. Okay, so you have lots of intestinal juice made up of mucus, digestive enzymes, water, electrolytes, and even hormones. The small intestine is going to secrete especially CCK, which is cholecystokinin. You're going to hear me talk about that a little bit more. But CCK is involved in making the gallbladder contract to release what is in the gallbladder. Duodenal ulcers, this is going to be when there is an erosion of the duodenal tissue, and it's about 4 times more common than gastric ulcers. And again, we have the different layers, right? There's a mucosal layer, and then there's the submucosa, and then the muscularis, and then there's the serosa. So as it starts to erode and go through and through the deeper layers, right? You've got blood vessels in here. This is when you get bleeding. This can create some serious issues here. Now, to try and protect the duodenum from duodenal ulcers, remember the stomach, which is an acidic environment, is dumping acidic content into the duodenum. So how does the duodenum handle the acidity? Well, if it can't, you're going to get a duodenal ulcer. But its good friend, the pancreas over here, the pancreas is going to push out sodium bicarbonate. Sodium bicarbonate is going to buffer that acidity out. And the gallbladder is going to push out bile, which also helps to buffer out some of the acidity. Okay. So when you look here, we do have the liver, we have the gallbladder in green, and the gallbladder has a cystic duct right here. This is the cystic duct. And so we'll put a C here for cystic duct. And then right here, this is the common hepatic. Now, all the common hepatic is the union or junction between the right and the left hepatic ducts. So the left hepatic duct and the right hepatic duct join at the common hepatic duct. And then you got the common hepatic duct and the cystic duct. These two join, and they join where the common bile duct is. Okay, so there's a common bile duct, and then there's a common hepatic duct. And then if you follow that common bile duct and we follow it down, it's going to come out right through here where that major duodenal papilla is. But so does the duct where you have the pancreas, right? Here's the main pancreatic duct, and it's going to come this way, and it too is going to join and release its contents into the duodenum to try and buffer it out. Okay. So the pancreatic duct and the common bile duct. So we have the pancreatic duct and the common bile duct. They both connect to the duodenum of the small intestine. In addition to digestive enzymes, the pancreas secretes sodium bicarbonate into the small intestine. The sodium bicarbonate from the pancreas and the bile from the gallbladder, they both help to neutralize the stomach acid to help try and prevent a duodenal ulcer. If the stomach is hyperacidic, you got the sodium bicarbonate and the bile that may be able to neutralize the acid in the small intestine and the residual amounts of acid that may be causing a duodenal ulcer. Okay? The causes of duodenal ulcer include all the basic causes of esophageal cancer. The pain that's experienced with abdominal and the pain is going to be just like with a stomach ulcer, it's going to be in the abdomen or in the back. The only difference is if you think back to the stomach ulcer created pain before they ate on an empty stomach. The duodenal ulcer often has the pain experienced after eating. So with a gastric ulcer, it's before eating. With a duodenal ulcer, it's after eating. The pain is usually sharp and burning, and sometimes it can be relieved if they just eat bland foods. Okay, the person that has the duodenal ulcer, they'll also experience gastroesophageal reflux disease, and they'll have bloating as well. And the therapy for the duodenal ulcer was this exact same for gastric ulcer and peptic ulcer. Now, you may have also heard of Crohn's disease. So it's important to just have a little bit of an understanding of what this is. It's an idiopathic inflammatory disorder, and it can affect both the large intestine and the small intestine. And most of the authorities believe that the condition has a combination of genetic factors as well as immune factors. 10 to 20% of all the people affected have some sort of positive family history. Smoking, dietary substances, and as well as an unhealthy microbiome in the intestines are also possible causes of the disease. Just to show you, this is what a normal lumen should look like. Notice it's nice and pink. It's nice and smooth. You can see the plica circularis in here, right? Those grooves that allow the chyme to mix beautifully. But look at the redness here. Look at these granulations here. This is Crohn's. This is very acute, inflamed, red, granular lesions throughout here. Very, very painful, very painful. These are all the different areas, believe it or not, that can be affected by Crohn's. But the most common area is this one right here. It's the ileocecal region. It's that junction right here between the ileum and the cecum, the ileocecal valve. So individuals that suffer from Crohn's, uh, sometimes they show no other symptom other than IBS, like having an irritable bowel. They can have diarrhea. They could be extreme weight loss. The malabsorption of nutrients, especially B12, folic acid, which is B9, and vitamin D. They can have abdominal pain. There could be blockages if severe enough. And oftentimes with Crohn's, they'll have to remove the section of the intestines that are affected. And I've known people that have had 6 to 8 feet of a resection, of intestinal resection as a result of Crohn's. Most people end up using immunosuppressants or immunomodulatory agents to suppress the immune system so they don't have this mounted, overwhelming, mounted response where their body is attacking it. They use like Humira is a common one. Okay, when I come back, we'll look at the large intestine.